Hello everyone, welcome to the test and discussion, and today I'll be primarily discussing regarding antiarrhythmic drugs. Physiology of action potential is the first thing that you got to learn. Unless you know this basic concept, you will never understand the arrhythmias and other aspect of the cardiology. So, question number 1. We have been shown a membrane potential changes in isolated cardiac muscle, and there are certain movements are getting shown, and which of the following ion sequence correspond to the region 1, 2, 3 on the graph respectively? The answer of this question is B, sodium, calcium and potassium. So before I go into the discussion, let us see once again the picture 1, 2 and 3. Okay, this is 1, 2 and 3 that has been shown in this membrane potential. Okay, right. The correct answer is B. Let's learn the basic concept. What is the action? What happen? What ionic changes occur in the action potential of a non-pacemaker action potential? Here I like to, before I really go, here I like to again emphasize, we have a SA node which has a pacemaker potential. Okay, and we have the cells, myocardial cells, which are non-pacemaker action potential. Action potential of these two, pacemaker and non-pacemaker, they differ entirely, and that is the most confusing thing in the whole cardiology. Let's leave the detail about non-pacemaker action potential. So we have a stage. So first of all, this is the minus 95 millivolt. This is stage 0, this is stage 1, this is stage 2, this is stage 3 and this is stage 4. Okay, so let us see what happened in each of these phases. Phase 0. Phase 0. Here primarily sodium enter. We are all aware that cell more is sodium is outside, and when the phase 0 start, sodium start entering the cell. Point number 1. In phase 0, sodium start entering the cell. So definitely, as the sodium, which is a positive particle, is entering the cell, and it is minus 85 to begin with, it will go up and reach, even it may cross the 0 millivolt also. So the carry home message, stage 0 is sodium enter the cell. You can see same thing is outside the cell. This is a membrane and this is the inside. You can see in stage 0, sodium is coming in. This is phase 0. You can draw the diagram like this. Phase 0, sodium is coming in. Till now I told you one thing. Well, after that, what happened? After that, so friends, phase 0, which I just mentioned to you, there is rapid depolarization. So you can write down. So what phase 0, rapid depolarization, because sodium is entering, it is going toward positivity, we call as depolarization. Okay, and as I told you, this is due to voltage gated sodium channel open. So what the sodium channel which I was describing, by which sodium has entered, it is a voltage gated sodium channel, and sodium rushes into the cell. Okay, fine, this is clear to you. After that, we have a stage phase 1. it is initial rapid repolarization. It is initial repolarization. Initial rapid repolarization. Point to be noted. This is again one confusing point. It is repolarization. Again, we go back to the diagram. You are getting immediately repolarized means it is coming toward it is going toward the negative side, coming back. You can say coming back. It is very initial. But why this happened? This happened due to two reasons. One is closure of the sodium channel. This sodium channel, which had opened during the stage Z, phase 0, they close. They close means no more positive particle entry. Stop, no more positive particle. But at the same time, potassium start going out. So that's why this was the rapid phase. This is the phase what we are getting is phase 1. So phase 1 is but it's a very transient phase. Why I'm going to discuss in the next slide. So friends, here sodium enter the cell. Here the potassium is going out. Potassium is going out. It's a rapid repolarization. Now we come to, after that we get a plateau phase like this. Plateau phase like this. Now what happened in the plateau phase? In the plateau phase, potassium keeps going out. But at the same time, calcium come in. Well, point to be noted, here in this stage phase 1, only potassium was going out. This is the plateau phase. Phase 2, plateau phase. Potassium going out, calcium coming in. So they are in balance. They are balancing each other. That's why we are getting plateau phase. Suppose equal positive particle of potassium goes out, equal positive particle of calcium come in. So as far as balance is concerned, positive will be maintained. That's why we generate plateau phase despite potassium going out. Now after this once they reach plateau phase, then again it comes like this. Again a rapid repolarization because potassium keeps going out. Now calcium stop. Here calcium stop. That's all. No more entry of calcium stop. Potassium still keep going out. So we get a so-called phase 3. Phase 3 we get only potassium going out. Point to be noted, repolarization start here. Repolarization started here. Okay. And it is coming up to this. Throughout this repolarization, potassium going out, potassium going out, potassium going out. So now by now you understood that depolarization occur with the sodium entry. Repolarization primarily occur by the potassium entry, and of course there is a calcium entry also. So sodium, calcium are entering in the action potential and the potassium going out, right? After this, so we talk more about plateau phase. As I told you, it is a distinctive phase of the cardiac action potential, and this is seen only in cardiac cell. It is not seen in other. No other tissue has this. So distinct feature is the classical feature that we see only in cardiac. And as I told you, there is the opening of the calcium channel blocker. What type of calcium channel blocker? L type of dihydropyridine sensitive calcium channel. Even if you remember, calcium channel is okay, but since you want to get a rank number 1 in any exam, you are the gold medalist, then you should know something extra. Everybody knows about calcium channel, but you should know they are L type of dihydropyridine sensitive calcium channel are there. So the point what I mentioned, the calcium is entering is by this channel. As I told you, the amount of calcium entry and potassium going out is same. That's why, as far as current concern, positivity or negative is maintained, and this is the reason plateau phase is there. Equal amount of positive by the calcium coming in, equal amount of positive going out via potassium. That's why it's a plateau phase. And after that, we have a late rapid repolarization. Remember, I told you, now calcium channel close and the potassium keep on going out. That keeps on going out. And finally, okay, this again, it come back to the resting membrane potential. Resting membrane potential. So now we talk about what happened in the resting membrane potential. Resting membrane potential is so-called diastole. Other name is diastole. What happened? Let us see. So, resting membrane potential is largely by potassium ion. Very, very important point. Resting membrane potential is primarily determined by the potassium ion. Okay. Well, one more thing. In cardiac, myocyte, this is about minus 90, or some books even write they minus 85 also. So in cardiac, resting membrane potential is somewhere minus 85 or minus 90. But remember, in skeletal muscle, it is minus 75. A point to be noted, in cardiac muscle, it is more negative, minus 85 or minus 90, as in contrast to skeletal muscle, where it is minus 75. And this is very essential to avoid arrhythmias. Somebody asks you why. Because it's minus 95. This is to avoid arrhythmias. Natural way of avoiding arrhythmias. Okay. So, as I talking to you, the highly negative resting potential of cardiac myocyte reduces the risk of arrhythmias. Because it's more negative. So we need a very high amount of powerful stimulus to generate any arrhythmia. Normally, none of the antiarrhythmic drug act at this place. Okay, to avoid. So that's why. So what we learn in this particular slide. In this particular slide, resting membrane potential is maintained by which ion? The answer is potassium. This is the first keyword to be remembered in this particular slide. Second, what is the resting membrane potential of a cardiac cell? Number 2, answer is minus 90. And third, what is the resting membrane potential of a skeletal muscle? Minus 75. So they are the 3 keywords to remember in this particular slide, and of course resting membrane potential is diastole. Now again in phase 0, what was we call as rapid depolarization, the first line, and second keyword is this is due to sodium entry. So there are only 2 keywords to be remembered in phase 0. Phase 1, it is rapid initial repolarization, first keyword. And what happened? Second keyword, potassium efflux. There are only 2 keywords. Plateau phase, this is due to opening of the L type of calcium channel, and here calcium entry occurs, potassium also goes out. So this is the first keyword and the second keyword. There are only 2 keywords to be remembered. Okay, calcium coming out, same amount potassium going out, and that's why plateau phase is there. Then in the phase 3, late rapid repolarization. This is due to calcium channel closes and potassium channel open. That's all. There are only keywords to be remembered in this. So now you see the sequence of what we say. If you go into diagram, so this is the what? Sodium enters, and this is the calcium enter and the potassium goes out. In the summary, that's why the answer is sodium, potassium and calcium. Golden line to remember. Cardiac myocyte action potential include the following three events: sodium ion influx, calcium influx and potassium efflux. And just to add on to you, this happen in phase 0, this happen in phase 2, and this happen in fact in stage 1, stage 2, stage 3. Most of the students think that potassium efflux occur in phase 3. That is true, but majority of students are not aware that potassium efflux occur in phase 1 and 2 also. This is very, so this is the summary. This is a summary of the whole question, or the whole cardiac action potential is squeezed into this particular slide, gives the whole complete information. Now, so I like to little bit more physiology I like to tell you. As I told you, yeah, stage 0, 1, 2, 3 and 4. But before I proceed, I must tell you some very important point. This is the action potential. This is the action potential. AP stands for action potential, duration of action potential. This is the absolute refractory period from here to here is absolute refractory period, but from here this is the relative refractory period. Relative refractory period. ARP is absolute refractory period. This is relative refractory period. Well, before I really tell more, little bit, there is variation in books. I have shown you almost the end of that is absolute refractory period ends with the end of the plateau phase, and after that comes the relative refractory period. But some of the books, they say that absolute refractory period is almost up to the middle of the phase 3. This is also written in some of the books. Anyway, as of now, I have to give you the most simplified version. So I have mentioned that up to the plateau phase is the absolute refractory period, and relative refractory period is this, what I told you, it is given. But why it is so important? Why I am spending so much of time? The clinical applied. The clinical CA stands for clinical applied. In absolute refractory phase, it is totally refractory. Totally refractory. No amount of impulse can generate any. No amount of howsoever strong stimulus is there, it will not generate any impulse here. No impulse will be generated because it is absolute refractory period. Second, clinical applied. Due to this quality only, the myocardium is protected from the generating arrhythmias. Otherwise, any small stimulus can lead to arrhythmias. So, somebody asked you why these arrhythmias cannot occur, because they have an absolute refractory period. Now this does relative refractory period, the clinical applied. Here arrhythmias can be generated if impulse is strong. If impulse is strong, arrhythmias can occur. And one more thing, any drug which is going to, and due to any reason, if relative refractory period is increased, they are more likely to have arrhythmias. I repeat again, if due to any reason relative refractory period is increased, it is more likely to develop arrhythmias also, about which I'll be talking to you later on. So friends, what are the key words to be remembered in this particular slide? We got absolute refractory period, yeah, and no amount of impulse can generate any arrhythmias. We have a relative refractory period, very strong impulse can generate arrhythmia, impulse. Any small stimulus, strong stimulus can generate arrhythmia. And the action potential is a sum of ARP plus RRP. This is the summary. So three keywords: absolute refractory period plus relative refractory period constitute action potential in a cardiac tissue. With this background, we move further. So golden line to remember. I'll be giving a lot of golden lines to you. The first golden line what you got was this. Get a second golden line. Golden line are the summary. If you know the golden line, you can know the entire cycle. So the golden line to remember. Rapid depolarization is phase 0. And just to inform you, sodium enter. Initial rapid repolarization, phase 1, efflux. Plateau, potassium efflux plus calcium influx. Then phase 3, potassium efflux. And resting, everything goes, they all get changed and everything come back to normal. This is the summary. The entire cardiac action potential summarized and squeezed into this one particular slide. Golden line to remember. So rapid depolarization, sodium influx or sodium enter. 1, potassium efflux. 2, potassium efflux plus calcium. 3, potassium efflux. 4, everything come back to normal, so-called they generate resting membrane potential. Okay, so we learned about action potential in a non-pacemaker. This question is about the pacemaker action potential. So they are generating and the specific type of cardiac cell, specific type. Changes are recorded in this, and they say what is happening when the arrow is there. Most likely this is due to calcium. Let's go back and see what the diagram shows. Oh, we are getting something like this. And he says what is happening at this. This is so-called calcium. So let's learn about the most confusing topic is that action potential of the pacemaker cell. In the previous question, we talked about non-pacemaker cell. So we are well aware that SC node has a, which is act like a pacemaker. Pacemaker means is the one which start. Let me give you a day-to-day example. We all have traveled in the train. In the train, we have a engine. Then we have many bogies or so-called coaches. Okay, we have coaches also. Yes, when the train moves, everything moves. but it is the engine which starts, which moves. When the engine moves, and that causes movement of the coaches also. If the engine is not there, the coaches will not move. Exactly same thing. SA node is the engine of the cardiac tissue or cardiac. So it starts automatically. And now that impulse will go to other places, AV node and other places. And this is how the cardiac contractility occurs. So what we learned the action potential in the previous question was what will happening in this. But now the action potential what happened in the engine or SA node. Let's learn about that. And that's a difference. So let us see. So friends, pacemaker, now it's a pacemaker action potential. Look into the slide. Well, around minus 70 or minus 75 is about minus 70 is the resting membrane potential of a SA node. Then phase 4 occurs, and then comes the threshold, and that phase 0 comes. And then is the phase 3. Phase 3. Come on, let us look into the matter. Phase 4, yes, it was there in the normal cardiac. Phase 0, it was there. But there is no phase 1, there is no phase 2. First and the most important point you got to know. No phase 1, no phase 2, which was there, and here we have phase 3. So one difference between the normal cardiac tissue and the SA node is absence of stage phase 1 and phase 2. Fine. Now let us see what happened in phase 0. What was there in the previous? Which ion enter in the cell? Speak out. Yes, sodium enter in phase 0. Here the calcium enters, not the sodium. Point to be noted. It's the calcium which is causing, so this calcium entry will lead to depolarization. After that, we have a phase 3. Phase 3 is potassium efflux. That is same what we happened in the normal cardiac tissue, but of course phase 1, phase 2 is not there. Understood? Yeah, with this background. Now with this background, having learned a basic thing, and so let's go. The graph of the question illustrates action potential of the cardiac pacemaker cell, as I told you. This is the cardiac pacemaker cell, so-called, which we find in SA node. And what is special thing about that? Because these SA node, they have a automaticity. This is the key word to be remembered. Only one keyword in this slide, automaticity. It is just like what I mentioned, that in a train, engine moves, rest all coaches follow. Engine itself can move and it can have the potential to pull other coaches. Same thing, automaticity occur in SA node. It generates the impulse, and that impulse will go and depolarize from this is the heart, SA node. Impulse come to AV node. From here, this is the AV node, SA node. This is the bundle of his. BOH is bundle of his. Then is the right and left branch, and they are Purkinje fibers. Right branch, left branch, and they are the Purkinje fiber, which is going to impulse to the whole cardiac muscle. This is the cardiac conduction tissue. So as I mentioned, this one which has a automaticity, it will generate impulse that will come to AV node. From AV node, it will be distributed all over the myocardium. So now what is the meaning? Somebody asked you via a question, what do you mean by automaticity? You should know the meaning also. An inherent ability to depolarize without any external influence. This is the golden line. Most of students, they know about, or they, well, SA node has a automaticity, but somebody asks, what do you mean by automaticity? And then they get confused. So now you got a clear-cut answer that SA node has a automaticity, understood. And what do you mean by it has an inherent ability to depolarize without any external influences? Remember, these AV node and all these, they will depolarize only when they get impulse from SA node. They themselves cannot in a normal situation, of course. So friends, only keyword to be remembered here is automaticity is inherent ability to depolarize without any external influence. And second point, now the question is, this depolarization occurs by which ion? Answer is calcium ion. Right? Understood the two keywords in this particular slide. Automaticity and calcium entry. So, well, we talked about phase 0. Phase 0 is calcium entry, but what happened in phase 4? Phase 4 also, now this phase 4 has a contribution in automaticity. There is a slow inward sodium current during this phase. This is known as funny current, or that means sodium entry, phase 4, sodium influx via funny sodium channels. Okay. Sodium entry in the phase 4, sodium entry occurs via funny sodium channel, what they write as I capital and F small is the funny sodium. This is the confusing. I'll be talking in much more detail just now. So now we talk about pacemaker potential which is generated in the phase 4. What is this? Again, let me show you diagram. I'm talking about this particular phase, phase 4. Okay, this was the phase 0. So how this pacemaker potential is generated? To write down, phase 4 is pacemaker potential. First keyword to remember. This is by slow influx of sodium. Point to be noted. Key to go. Point to be noted that when we discuss in the question 1 about phase 0 of the normal cardiac tissue, it was rapid depolarization by sodium entry. But I am talking about phase 4 of SA node, where it is due to slow influx of sodium. And so this is a slow sodium entry, not fast. And at the same time, the efflux which was going on, of course, remember, this is the, so this was the phase where potassium was going out, phase 3. Now this stops. Potassium doesn't go out, they stop, but sodium start coming in. So in the resting stage 4, potassium stop going out, sodium start entering in. Okay, so now that means more and more positive particle, and now more and more positive is coming in. It start going like this. and once it reaches minus 50, then the calcium start coming in. Okay, calcium cha. And this is by T-type calcium open. Very, very important point. In SA node, calcium channel open I have been telling you, but it is a T type, which are T type. Remember, the normal cardiac tissue, it was L type. They are the basic. These are the places where the student gets stuck up, and they have a lot of relevance when we'll be using antiarrhythmic drugs. So now friends, again we go back to the same slide, right? Same slide, we go back and we understand better so what we are getting here, sodium is entering the cell. Sodium is entering, it will lead to positivity. Once it reaches around minus 40 or minus 50, this sodium will stop. My job is over. And now calcium will take over. It starts going in and goes via T. And once it reaches, it stops, and now potassium starts going out. And here again, sodium start coming in via what? Funny sodium channels. So now you have to answer the question to me. In pacemaker action potential, what happened in phase 4? Sodium enters the cell. Number 2, is it a fast movement or slow? It is a slow movement. Next, which channels are used? Funny sodium channels. Okay, this 3 point about phase 4. Then in phase 0, what happened? Calcium enters the cell. It enters via what? T-type calcium channels. Then in phase 3, what happened? Potassium efflux occur. What about stage 1 and 2? They are not there in SA node. This is the basic. Well, now a little bit of applied. We have a drug called ivabradine. It's a new drug, widely discussed in all the conferences. A very, very important point. Ivabradine. We all know the clinical applied. This drug reduces heart rate. It decreases heart rate. How come? How come it inhibits heart rate? The reason being it acts on, it blocks sodium entry. It blocks sodium entry via funny sodium channel. IF stands for funny sodium channel. So that will reduce the sodium entry into the cell. Definitely this firing rate will be reduced, the heart rate will go down automatically. So what question you should know? What is the effect of ivabradine in our body? The answer is it reduces heart rate or it causes bradycardia. Second question, what is the site of action of ivabradine? It acts at the funny sodium channel. Thereby, it reduces the entry of sodium into the phase 4. Slope is reduced, the heart rate will be reduced, firing will be less. So there are 2 clinical applied. So I hope you are clear about this particular slide also. And you know, so this was all the stage phase 4. Now, okay. After that, we are getting upstroke, which is due to slow influx of calcium, And so after that we have a calcium influx, and that is followed by depolarization, then followed by phase 3 repolarization, which is due to outflow potassium current. So in phase 0 calcium is entering, and in the repolarization, this is repolarization due to opening of the potassium channels, and that lead to efflux of the potassium. Right, sir. So now we are clear about it. To summarize the whole show, in phase 4 sodium enter, phase 0 calcium enter, and phase 1 potassium goes out, right? So rest all the options are incorrect, so I don't need to discuss all these other options. So friends, golden line to remember. In cardiac pacemaker cell, phase 0 depolarization is made by the influx of calcium, and this phase 0 differ from the non-pacemaker. In non-pacemaker, the phase 0 was due to sodium, but here the phase 0 is due to calcium influx. This is summary of what we discussed, and you can add it more point. Phase 4 is sodium influx, funny sodium channel, and phase 3, this was the phase 4. Now phase 3, potassium efflux. Potassium efflux, that was there in the cardiac action potential also. And finally, no need to say that here phase 1 and phase 2, they are not there, they are absent. So friend, this is the summary, entire summary of the SA node action potential. Phase 0 is, so first keyword, phase 0 is by what? Calcium entry. And in cardiac muscle, the phase 0 was sodium entry. Here in SA node, the phase 4 is mainly due to sodium entry. It enter via what? Funny sodium channel. Which drug act at funny sodium channel? It is ivabradine. And phase 3, potassium efflux, and phase 1, phase 2, it is not there, it is there only in cardiac myocyte. With this, we come to question number 3. We are getting a 84-year woman. She has a confusion, dizziness, and she was told that phase 4 depolarization is caused by which of the following? Okay, which of the following causes stage 4 cell in this? What is talking about? That her rate did not change with the patient was instructed to perform a Valsalva maneuver. Okay. In 24-hour Holter Monty, there was a period of sinus bradycardia. Oh, and which phase 4 of SA node? Straightforward question is there. The increase sodium entry into the cell. I think I don't need to discuss this question. He straightforward asked the question that what happened in stage 4? Answer is sodium entry via funny channels. Okay, right? Question number 4. Well, membrane potential changes in some atrial myocyte are recorded in the graph. Which of the following stimulus was most likely applied to cardiac muscle at a point indicated at the arrow? Let us see. We go back to again. Well, you can see the impulse coming, and now, oh, it has slowed down. Just see. it has slowed down drastically. Drastically slowdown has occurred. What he is asking, which drug was given to slow down this action? It's a lovely question. Beautiful question. Really, it's a good applied. Answer is adenosine. Now I'll be using the applied. I'm sure some of you may have done some wrong about this question, but don't worry, answer adenosine. Why? Now I'm using the same knowledge what we got in the previous questions. Okay, well, adenosine and acetylcholine, they act on the phase 4. Oh, phase 4. Phase 4 is the one in the nodal cell. Okay, it's the one which reduces the rate of spontaneous depolarization. Spontaneous depolarization, phase 4. Remember, automaticity was due to inherent quality of to depolarize in phase 4. So these two drugs, adenosine and acetylcholine, they are going to act, and we all know very well. Let me give you example. We all know atropine. Atropine increases heart rate. Yes. We also know that atropine, acetylcholine, it reduces heart rate. It reduces heart rate. Atropine causes increased heart rate. Why? Acetylcholine is acting at again phase 4 the way ivabradine acted. That's why they reduce the heart rate. Phase 4 again, other drugs which are acting at phase 4 is acetylcholine and adenosine. This how they reduce the heart rate. That's why adenosine is used in condition like supraventricular tachycardia, where the atrial rate is very, very high. Atrial rate is very, very high. So we use adenosine which acts transiently, so it slows down the heart rate by acting at what phase? Phase 4. Agreed? But not only that, they have some other beautiful. It activates potassium channel and it prolong flow. So it prolongs, that means let potassium go out, let potassium go out, more and more potassium go out. That means it will remain negative. Definitely more and more potassium goes out will make it more and more negative. More and more negative will again, it will slow down the next phase of the cardiac cycle. So friends, point to be noted, now question will come to you. Adenosine act at what phase? Your answer should be phase 4 and also phase 3. So it slow down the sodium entry, or you can sodium entry into the cell at stage 4, and it also causes more efflux of potassium in phase 3. Ultimately it becomes more and more negative. More negative will further slow down the beat. That's the reason adenosine is used to stop supraventricular tachycardia. Okay. Well, it also acts on the calcium channel also. Oh, very interestingly. Now you are going to ask me a question. So if you look into this, they are acting at, we have this, the is the normal assay potential. Sodium entry blocked by adenosine. Calcium entry blocked by the adenosine. But it causes more and more potassium to go out. Let go out. So it becomes more negative. The net result will be, the point to be noted, pharmacology nicely correlating with physiology. The 3 reasons why adenosine is one of the best drug to be used to terminate supraventricular tachycardia, and one more advantage, this drug has a very short half-life, so action terminate very fast. With this background, so we learned lovely thing about this drug. Well, as far as norepinephrine is concerned, which is a catecholamine, it open L type of calcium channel, and it also open the sodium channel into the nodal action potential, right? So they lead to more rapid depolarization, right? So this is not the answer to the question. Remember, in our graph what we showed was the reduced heart rate. Digoxin doesn't have this action at all. It has altogether different, that I'll be discussing in the coming questions. Angiotensin 2 and aldosterone, none of them have a action on the phase 4, none of them. Okay, even norepinephrine doesn't have action on phase 4. Now the golden line to remember. Action potential of pacemaker cell include phase 0, 3 and 4. This point I mentioned in the previous question also. Phase 4 occur due to spontaneous depolarization, and this is due to closure of potassium channels, slow influx of sodium via funny channels. And later on, in the later phase of depolarization, there is opening of the T and L type of calcium channel occurs. But this occurs in the later phase of the depolarization. Acetylcholine and adenosine, they reduce rate of spontaneous depolarization of cardiac pacemakers. Again, the beautiful summary of the whole show. So you can write down action potential of the pacemaker cell include phase 0, 3 and 4. First keyword. Second, in phase 4, spontaneous depolarization, potassium channel close, slow influx of sodium, which is the main event, and there is later part of depolarization, opening of the T and L type of calcium channel occurs. And acetylcholine and adenosine, they reduce the rate of spontaneous depolarization. Okay. Having learned the basic concept, now I'll be talking to you regarding antiarrhythmic drugs. Okay. A new antiarrhythmic medication, drug A, is tested in several animal experiments. The action potential of ventricular muscle cell are recorded before and after administration of the drug. Okay. Black curve is before administering. So that is the black curve. This curve is before giving the drug. And this red curve is after giving the drug. The action of drug A most likely resemble effect of which of the following? Answer is disopyramide. Let's go back to the graph again. Let's see what is happening. What we notice, of course, this cardiac, this is sodium entry occurs. That we know very well. And in this normal, this is the normal action potential. This is the duration of normal action potential in this. Now what changes have occurred in this? When we gave the drug, first of all, this slope has shifted to right. Second, the duration of action potential has increased. So there are two things that we have noticed in the duration of action potential is increased, and this slope, it has been slowed down. That means it has done something with the sodium entry. So net result is they have affected sodium entry and they have increased the duration of action potential, and sodium entry has been slowed down. Two effect we can see, sodium entry have slowed down, that's why the curve has gone like this, and we have seen the duration of action potential increase. This is the what done by the drug disopyramide, which is a class 1A drug. Okay, so let's learn what are the various antiarrhythmic drugs we have. Accordingly, we'll discuss. So let's learn how we are well aware that antiarrhythmic drugs are classified into class 1, 2, 3, 4. I'll be discussing other drugs categories soon, but first we discuss class 1 drugs. Class 1 drug, they are known as sodium channel blocking drugs. Okay. Well, you can see here also they have really blocked the sodium channel only. That's why slope has gone toward right side. Lower slope means it will really slow down the impulse generation. That's the meaning, understood. Now class 1A drug, which are the drugs which are in this category? Disopyramide, quinidine and procainamide. This you should know. Okay. There are the three important drugs which belong to this category. Well, how effective are they? Are in phase 0. Remember, all these three will be acting in the phase 0. Why phase 0? Because this is phase 0. So all these will be primarily, main site of action is phase 0 with the sodium getting depolarized. So how powerful? They are intermediate. And very important point, effect on the duration of action potential, it is increase. Okay. Now class 1B drugs. 1B drug include lidocaine, tocainamide and maxilitine. This is the most widely used drug. This is also known as lignocaine. Lignocaine and lidocaine are the same. How is effect on the phase 0? Effect is weak and they shorten the action potential. Point to be noted. Class 1C, it includes morphine, flecainide and propafenone. Okay. Point to be noted, flecainide is class 1C. Point to be noted, tocainide is class 1B. This is the confusion. People always think that this tocainide belong to class 1C. No, it is class 1B. Don't commit this mistake. Now, phase 0, strong, very powerful. And what about action potential? No changes. Friend, this is a slide worth $1 million. This summarizes 90% of the class 1 action, drug, everything has been summarized. So since it is the fundamental of the whole thing, so I like to talk, again I like to revise. So now you have to answer me. What is the main action of class 1 drug? They are sodium channel blocker. Point number 2, this class 1 drug, they act on which phase of the cardiac action potential? Answer, phase 0. And phase 0, sodium entry occurs, very rapid depolarization in the cardiac myocyte. Next, what are the example of class 1A drug? Disopyramide, quinidine and procainamide. And what happened to action potential? It increases. Very, very important point. Class 1B drug. Okay, class 1B drug. What they are going to do? Again, they are sodium blocker. Example, what example? Lidocaine, tocanide and maxilitine. Effect on the phase 0, weak. And effect on the action potential, reduce. Class 1C, morphine, flecainamide and propafenone. Action on phase 0, very strong, and action potential, no effect. These words that I'm going to discuss, I've told you just now, I'll be needing again and again in the subsequent questions with this background. With this background, let's go to diagram again. So now things are clear to us. Things are clear to us. Things are clear? What clear? First of all, it has reduced the slope of this phase 0. This is it is sodium blocking drug. Agreed? And it has increased the duration of action potential. Now things are very simple. Well friends, at a glance only, I'll be showing this graph, different type. At a glance only, you can, this is the answer. Why? You have to look into this slope, turning around, turning on the right side as compared to normal. It is a class 1 drug. Second thing, you look into the graph regarding this action potential. It is increase is class 1A. Suppose we get like this. Suppose we get like this. So what is normal action potential? What it should be? Class 1C. Suppose you get like this. Suppose you get like this. What is this? Class 1B. The action potential had shortened down. That's all. This is so simple. At a glance only you can find out. Now with this we move further. So as we have seen in the diagram that sodium blocking action is there and action potential duration is increased. The out of these, this is what? Class 1B. It doesn't increase action potential duration. Propranolol is a beta blocker. It has nothing to do with this. Diltiazem is a calcium channel blocker. It has nothing to do with this sodium channel. Flecainide is 1C. It is a sodium channel blocker, but it doesn't increase duration of action potential. This also rule out. So I hope you are very clear about it. Very clear about it. Okay. So the friends, class 1A drug, they are reducing the slope of sodium entry, and they are causing increased duration of action potential. Very simple. This is regarding lidocaine. Look into lidocaine. Lidocaine, it is causing, of course, it is causing reduced slope and they are reducing the action potential. Yes, agree. So we agree it's a class 1B because duration of action potential reduced. But one more thing you notice it. Look into this graph, look into this sodium and look into this one. Look into this one. Look into this. See, this slope is like this. But in this diagram, the slope is like this. Why? Why the slope is more here, less here? Any answer? Write down the answer in your copy. Why is it so? This is class 1A. And this black one, this one is class 1B. Write down the answer why the slope is so much more here, less in 1B. Write down the answer. Well, the answer is here. Answer is here. Class 1B is a very weak inhibition of phase 0. Class 1 is intermediate. That means at least more powerful than the 1B. So now we can understood why this slope is more and less in 1B. 1B is a very weak sodium channel blocker. Got it? Yes. Well, so this is the lidocaine, what I told you. Now look into this flecainide. Look into this. This is class 1C, yes. And no effect on action potential. No effect. Action potential remains the same. But look into the slope. This is what we are getting, very powerful. Very powerful. Fine. So friends, now if I have to tell you, this is class 1C. Now I tell you this is class 1A. And now come the class. Now come the class. This is class 1B. Look into two things. Slope. Slope. Very powerful is class 1C. Intermediate is class 1A. Very less is 1B. Second thing, look into the duration of action potential. Increase by class 1A. Normal class 1C. Reduce by class 1B. That's all. That's all. So now friends, any graph at a glance only, this is the answer. Only in one glance, in 1 second. So golden line to remember. Class 1A drugs are like quinidine, procainamide and disopyramide. They are the sodium channel blocking drug. They act on the phase 0 and they prolong repolarization as well as refractive period. So they prolong refractive period, and that's why duration of action potential is reduced. Increase duration of action potential. So the key word to remember are, they are the sodium channel blocking drug and they increase the duration of action potential. Only two keywords to remember in this slide. Now every basic concept you understand. Now the subsequent question you will find they are so easy. We don't have to devote much time. Well, question number 2. We got a new drug, high affinity for activated and inactivated sodium channel, but have a little affinity for the resting sodium channels. Oh, something extra we are going to get now. So an experiment is devised to maintain sodium channel in the inactivated state for a prolonged period, during which they are exposed to new drug. Okay. After allowing the sodium channel to return to resting state, the speed of drug dissociation from the sodium channel is recorded as shown below in line 1. Dissociation curve for quinidine is given for comparison for line 2. Quinidine, we know it's a class 1A drug, that we know. So now they are asking us to compare with the new drug with the quinidine, which is a well-known class 1A drug. It is a sodium channel blocker. So line 2, this is the line 2. This is quinidine. Yeah. And what he's talking is line 1. Oh, he's asking about this line, class line number 1. Something very interesting, very nice, beautiful question. It needs a lot of input of the basic concept. Let's discuss. Well, this is due to lidocaine. Why this the answer? Why not others? For that we got to know a lot more about basic concept. Okay. So we all know very well that phase 0 is a voltage gated sodium channel state. Now let's talk more about the sodium channel, what we have been discussing so far. Look into this. This is a sodium channel. It is open now. You can see it is open and sodium can very well go. Agreed. Agreed. Sodium can very well go. The gate is open. Well, now the gate is closed. Is closed. Definitely it's closed, inactivated. Sodium cannot enter. Okay. Well, now we have got resting stage. Resting stage. Look into this. Look and compare with this. This resting stage, this is reduced. Size of the road has been reduced. This is the resting stage. And then we have a look into this. Inactivated stage. Closed. That means closed also. And you can see this is a partial closure. This need again, this I'm sure all of you, most of you are listening for the first time. This is the bottleneck for 99.9% students. So I'll spend more time. Let's go back. Let's go back. We talk about voltage gated sodium channels. They are open, totally open. So sodium can very well move in. Fine. Then we have a closed, sharp closed. This is the closed. Sodium cannot enter it. Then we have a resting stage. resting stage, this channel has been narrowed down. So you can see definitely it will restrict the sodium movement. And now this channel also narrowed down and channel closed also. It is totally inactivated. This is the basic thing that we discussed. The rest of the thing you will understand better. So look into this. Well, one thing is very clear. It represents a class 1A antiarrhythmic medication. And these all sodium channel blocker drug, they block voltage gated sodium channel in the cardiac pacemaker cell and the myocytes. Sodium channel blocker are the class 1 drug. And now come the gold medal line. And that will tell you why they even in the class 1A, B, C, what some differences occur due to this reason. This the gold medal. They exhibit use dependent. This you note down. Use dependence is the key word that you got to remember in this particular slide. What do you mean by use dependence? It's a phenomenon in which tissue undergoing frequent depolarization become more susceptible to blockage. Any tissue which is getting frequent depolarization is more sensitive to so-called, the meaning is use dependent. More we use, more likely to get blockage. Okay. Now, one line which I'll be repeating 2 times. Use dependence occurs because sodium channel in rapidly depolarizing tissue spend more time in activated and inactivated state. Use dependence occurs because sodium channel in rapidly depolarizing tissue spend more time in activated and inactivated state. Thus, all more binding time for the drug. That means, remember, we are getting in the rapidly depolarizing, activated and inactivated state, they are more likely to bind. You still need to go, in the coming slide, I'll be telling you more, then you will understand better. Now, what we discuss that in the that class 1C, they have a strong, class 1B was intermediate and class 1B was weak. Now, class 1A drug, sodium channel binding strength, class 1C, AB. This is the reason what I told you, binding capacity is more with 1C, most with 1C than 1A and 1B. That means 1C are the most powerful to get attached to the sodium channels. Okay. So, U dependent is more pronounced with class 1C. Because why? Because they have slow dissociation in sodium channels. Oh, look, this is the sodium channel, and this is the class 1C drug. It goes and get attached to sodium channel. Oh, it remain longer time. Look into this. Now class 1A, they come, go. Class 1B, look once again. This is the sodium channel Okay, sodium channel. This is class 1C drug. They come and get attached. Now there's, oh, longer duration. Now we have a class 1A, class 1B. What you notice, the duration of attachment of drug to the sodium channel was much more in class 1C, longer, class 1A, class 1B. This is the use dependence. Got it? Okay. So it is ultimately we understood why class 1C is very powerful, because they stay for longer duration. Well, now this effect which is getting attached, the drug getting attached to the sodium channel is enhanced with tachycardia. Okay, tachycardia. Why? Tachycardia means these tissues are getting more and more in use. What I said, it's a use dependence. So this result in increase in sodium channel blockade, and this how they slow down the tachyarrhythmia. Next, what I want to convey the message is, oh, it looks very confusing. Don't worry. Now, what all you have to remember in this particular slide. Point number 1, class 1A drug, they have a use dependence. Use dependence is there. Number 2, second point, class 1C is the most powerful as compared, more powerful than class 1A, which is more powerful than class 1B. All because slow dissociation. This is point 3. Class 1C goes and doesn't go away. They have a slow dissociation. That's why they have a longer action is there. Okay. Now something very interesting to talk. Again, top level knowledge is this. Predominant use dependent effect of class 1C that causes delay in conduction speed is out of proportion to refractory period. It slows down the conduction tremendously. Tremendously it slowed down. Very tremendous slowdown in the, and this effect is more in the ischemic tissues. Ischemic tissues. Okay. This is the normal cell. Normal cell. It slow down the speed. Slow speed. Slow speed. This is the ischemic cell. Speed is reduced drastically. That means virtually it's virtually slow downs the ischemic tissue speed drastically. But that's not good. That can itself, it can again, so in itself can lead to arrhythmias. This class 1C drug, because they strongly slow down the speed in the ischemic tissue, they themselves can produce arrhythmias. That's why these cells, class 1C drug, are never used. They are never used in ischemic or structural heart disease. So I repeat again, class 1C drug like flecainide, they are strongly bound to sodium channels. Number 1. They slow down the conduction. Yes, they are very powerful. But in ischemic tissue, they slow down the transmission badly, very badly. And the ischemic, in that situation, ischemic tissue itself can produce arrhythmias because the normal impulse is totally gone. So summary is, which drug, antiarrhythmic drug, should not be used in ischemic heart disease? Flecainide. Flecainide is what? It's a very powerful sodium blocking drug. Number two, very powerful sodium blocking drug. Number two, it doesn't change the duration of action potential, but it can extremely slow down the conduction in the ischemic tissue, and that's why it should never be given in ischemic heart disease. Now let's talk about class 1B drug. Class 1B drug is lidocaine. Dissociation is so rapid, there is minimal cumulative effect. So class 1B, they go and they don't get attached. They just go, they go as a visitor. They go and come back. They go and come back. So, and that's why they are not, they have a little use dependence. So they have a little use dependent because they are only acting, only have a transient stay, they don't stay for a longer time. But now point to be noted, since they go and get attached and come back very fast, so they are very good for ischemic myocardium. In contrast, flecainide, it has really suppressed too much, which we don't want. And flecainide was contraindicated in ischemic heart disease, and these are class 1B. They are very effective for ischemic myocardium. Okay. Now why? Because they delay sodium channel transition from inactivated to resting stage. Okay, so that's why they are very good drug to be used in ischemic heart disease. Flecainide are not. So friends, class 1B drug are useful for treating ischemic induced ventricular arrhythmia like in myocardial infarction, which is the most common cause of death after MI. So now you are clear about it, that why we use lignocaine in arrhythmias in after ventricle. Remember, ventricular arrhythmias are very common after coronary artery disease. We want a drug safe, which should not affect much of the ischemic heart tissue, and lignocaine is the best drug. Amiodarone is a class 3 drug. Class 3 drug, it acts on the potassium channel, about which I am going to discuss little later on. It has got nothing to do with what we are talking about. Disoporamide is a class 1A drug. It represents the line 2 on the graph. Again we go back. Line 2 is the quinidine. Line 1 is what we talk about. Shorter duration of action potential is class 1B, and flecainide, line 1C. Again, you remember this was the line 2, this is line 3, and this is line 1. 1, 2, and 3, simplified version. A simplified version is, this is the 2, this is line 2, line 3, line 1. This represents class 1B drug. This is class 1A drug, and this is class 1C drug. Most simplified version is this. Or to simplify the matter to what you should remember, that ultimately use dependent. Class use dependent is the feature. Again, the question can be asked you this way also. Which of the following drug is use dependent? Any drug of class 1. Number 2, most powerful is 1C, intermediate is 1A, and weak is 1B. And third question, Drug of choice for ventricular arrhythmias in coronary artery disease, class 1B drug, lidocaine. Which drug should not be given in ventricular arrhythmias in MI, class 1C? That's all. If you remember these three lines, you are through from this question. Okay. So, golden line to remember. Use dependence describe the phenomena in which higher rate of depolarization lead to increased sodium channel blockade due to channel spending less time in resting state. Class 1A sodium channel blocking strength is more in 1C, 1A and 1B. Class 1C most use dependent and class 1B have the least dependent action because class 1C is most powerful bound to sodium channel, class 1B is a weak drug to bind to the sodium channel. The keyword to, so in this also, this is the first keyword use dependent is class 1A drug, and this is the second thing, that's all. In this also, just remember these two are the most important keyword that you got to remember. An additional point was class 1C we never use in coronary artery disease and class 1B we most commonly use in ischemic heart disease. Now the question is very easy for you. Well, we got a drug effective in both atrial and ventricular arrhythmias. QRS complex prolonged, but less effect on the QT interval duration. QT interval not affected. Okay. Which of the following action potential is curved? Let us see. Answer is B. Let us see. Let us see. So let's discuss ECG. The QRS complex denotes ventricle depolarization. Let me draw a diagram. ECG. Basic concept about ECG. Yeah. This is the P wave. This is due to atrial depolarization, so-called atrial systole. Electrically, there is depolarization of the atria, but mechanically, you can say atrial systole or atrial contraction, whatever you can see. This is the Q wave. This is the R. The down is Q, up is R, and down is S. This is the QRS. This indicates ventricular depolarization or we can say ventricle systole. Ventricle systole is occurring mechanically, and this is the T wave, and this indicates ventricle repolarization, ventricular repolarization. Okay. So, with the basic QRS complex ventricle depolarization, which I told you just now. This occurred during the phase 0, where the sodium is entering into the cell, okay, which is represented by option B. Agreed? So depolarization occurs when there is a rapid sodium movement into the cardiac myocyte, which is same thing. He's talking about phase 0. That we know very well. Now this drug, phase 0, this is going to block the phase 0, but point to be noted in this, there was no effect on the action potential. And the one drug that out of the class 1A, B, C, one drug which does not affect QT interval is class 1C. Okay, so this drug does not prolong QT, so it is drug like class 1C is propafenone is the answer in this. What is option A? This tells you phase 4. Look into the diagram again. This is phase 4, okay, resting membrane potential, and none of the antiarrhythmic drug act on this, as I mentioned to earlier, okay, but this can be mediated, so none of the antiarrhythmic drug and stage 4, so this is option is already ruled out. Option C, this is a phase 1. Phase 1 is the rapid early repolarization. None of the antiarrhythmic drug act here also. This also rule out. Look into C. Here these antiarrhythmic drugs usually do not occur, especially in phase 6C. Plateau phase is the one which is there by calcium entry and potassium efflux. And finally E, this is the rapid repolarization. Phase 3 repolarization is the QT interval in EKG. QT interval is this one. From the QT interval is the complete cardiac cycle. Remember, this represents the ventricle systole, and this represents ventricle diastole. The QT interval indicate the complete cardiac ventricle systole and diastole is there. Okay. Golden line to remember. QRS complex correspond to ventricle depolarization. It is phase 0 of action potential graph. Ventricle myocyte depolarization is mediated by inward sodium movement, and this is modulated by class 1A antiarrhythmic drugs. Question number 4. We are getting a 47-year-old male. Chest tightness, sweating and palpitation, rate is 100. An esmolol was given to relieve symptom, and EKG recording does this medication exert its greatest effect. Okay, what is going to do it? We are getting P wave. This is the PR interval. The P wave, PR interval. Okay. This is the QRS interval. Okay. And this is the QT interval. This is the QT interval. Simple. PR interval, QT interval, and this is the QRS interval. Let us see. So again, some basic concept. P wave represent the atrial depolarization. The point I told you, atrial depolarization or atrial contraction. QRS indicate ventricle systole or depolarization. After that, up to the T is repolarization. The question is, what happened to atrial relaxation or atrial diastole or atrial repolarization? There is no separate wave, for atrial repolarization. It gets mixed up with QRS complex. As such, there is no separate. This is first point. So P wave is atrial systole or atrial depolarization, but atrial diastole has no separate. Okay. And the QRS complex indicate ventricle depolarization, that is ventricle systole. Now the PR interval is the time from the beginning of atrial depolarization to beginning of ventricle depolarization. Let's go back. This PR interval this what it tells the atrial contraction or systole, whatever you can say, contraction I am writing for easy understanding. This is same as atrial systole. It is also same as depolarization. Now in the let's go back to cardiac cycle. In the cardiac cycle, atrial systole occurs when there is late ventricular diastole. Atrial systole occur when there is late ventricular diastole. Okay. After that starts ventricle systole. When the ventricle systole is occurring, that time occurs atrial diastole, also called repolarization. That's why what I was telling you, that when the atrial diastole occur or ventricle atrial depolarization occur when there is occurring a time of ventricle systole, so that merges. So that's why we don't get any wave for the atrial diastole. And now this is represented by the QRS complex. Now you understood? Yeah. So this is so-called QRS complex is ventricle systole. Well, PR interval impulse is coming from SA node and it has to come to the AV node, and impulse has to go down in the ventricle so that ventricle will start contracting. So this time, so impulse has to come from SA node or atria to ventricle to be more precise. So this interval is called as PR interval. PR interval is the impulse time coming from SA node till it reaches the ventricles where it start contracting. So PR interval primarily is before the ventricle systole. And one of the main contributor to PR interval is AV node. Why? Write down the answer in your copy. Why? PR interval is also determined mainly by a AV node also. Reason, write down. PR interval. The reason is when the impulse comes from SA node to AV node, it comes very fast. But at AV node, it takes lot of time. So there is, AV node has the maximum refractory period. That's why AV node takes lot of time of the PR interval. Okay, what do you mean by? Remember, this speed is very fast. This speed is fast, this is fast, all are fast. This is slow. Well, I can give you a day-to-day example. You are going on a highway. You are going on a car and your speed is very fast. Finally, you find a toll, where they collect the road tax. Definitely. And suppose you want to pay cash money, you don't have a tag in your car. You come to this place, you stop. You pay the, and of course you have to reduce speed also, you pay the cash, then again you start. You had to slow down and you have to stop here for some time because you have to clear that road tax. So here speed very fast, here speed very fast, here speed is slow, or whatever you can say. Same thing is AV node. So that's why the PR interval is the point of impulse coming from SA node till ventricle systole start, and one of the contributory factor for a PR interval is delay in the AV node. With this background, we go back. So longer the PR interval, the longer it will take from electrical stimulus to travel from SA node to ventricle via AV node. Definitely, we understood. Okay. So now any drug which will be acting on the AV node will cause prolonged PR interval. The beta blocker, esmolol is a beta blocker. It primarily acts on the, it has a very main role in AV node also. Okay. So they increase the PR interval. Beta blocker don't affect QRS and QT interval. They don't have QRS interval they don't affect much. They primarily affect the PR interval. Okay. Well, the T wave represents the rapid phase or ventricle repolarization. Okay. They are not affected by the beta. Remember, ventricle repolarization means ventricle, they are the so-called repolarization means when it is relaxing, right? It is not affected by the beta blockers. QRS complex is ventricle depolarization, not affected much by the beta blockers. ST segment and T wave represent the ventricle repolarization. Remember, ST and T wave, they both represent ventricle repolarization. But T wave represent rapid repolarization. They are not affected by the beta blockers. QT interval is the entire, as I told you, QT interval is the QRS complex like this. This is the QT interval, which indicate both ventricle systole and diastole. That is not affected. Esmolol will not affect QT interval. QT interval is affected by the class 1A and 1B drugs. So golden line to remember, beta blockers, they include like esmolol, they slow AV conduction. Delayed conduction through the AV node lead to prolonged PR interval. That's the prime effect of beta blockers on effect on the ECG. Golden line to remember. Question 5. We have a patient of atrial fibrillation. He get dophytylite and arrhythmia get resolved. What is the main action? What is the main action? Answer is E. Answer is E. E is this. This is the what? Is the phase 3. What happened? Potassium efflux. That we know, we read a basic concept. Okay. So friends, same diagram which I have already shown you. This is a SA node and this is okay. Well, just to refresh your knowledge, in SA node we have a action potential. Sodium entry occurs via funny sodium channel, calcium entry and potassium efflux. This is what happened in the SA node, which is a pacemaker, and here is a non-pacemaker cardiac muscle. In phase 0 sodium entry, phase 1 potassium efflux, phase 2 potassium efflux and calcium entry. Phase 3 potassium efflux, and this is the resting membrane potential. So what you notice, the depolarization occurred due to sodium entry, repolarization, potassium efflux, potassium efflux, potassium efflux plus calcium influx also. Just a quick recap of the cardiac cycle. Remember, in SA node, depolarization is occurring by calcium. In the routine cell, it is by sodium. And there is no phase 1, no phase 2 in SA node. So, action potential pictured here in the cardiac cycle is phase 0, 1, 2, 3, 4, which I just mentioned to you. And dophytalide is a class 3 drug. It is a potassium channel blocking drug. Okay. That slow down the potassium efflux from the cardiac myocyte. That I told you, it is a class 3 drug. This is the site of action of class 3 drug. That means they are potassium channel blocker. So they affect mainly the phase 3, option E in the graph. Right? So dophytalide is a stage 3, class 3 drug. It is acting at the potassium channel. Hence answer is E option is there. This will be those by class 1A. This is class 1 drug. This is by the class 4, so-called calcium channel blocker, and this is by the class 3 drug. So simplified version. Right? So this option B is class 1A. All this golden line to remember. Class 3 drugs, they block potassium efflux from the cardiac myocyte. They prolong the phase 3 of the myocyte action potential. Question 6. A 60-year-old arrhythmia and to T patient, and it causes prolonged QT interval. But despite this, there is low incidence of torsadipoitis. Answer is amiodarone. What he is asking? We got one patient who got arrhythmias. Which type of arrhythmia? He did not mention. We use the drug and it causes prolonged QT interval also. Okay, agreed. But it does not lead to torsades. What is this? Let's learn some basic concept. Well, friends, this is the normal. Okay, this is the Q wave, the T wave. This is the QT interval. This is T wave, this is Q wave. And we have learned by now that QT interval represents entire ventricle cycle, systole and diastole. This much is the ventricle systole and this much is the ventricle diastole. That we agreed. So-called depolarization and repolarization. And we learned about the QT interval when we talk about class 1A drug. We know that class 1A drug, they cause prolonged QT interval. Class 1B, they reduce QT interval. Class C, they have no effect on QT interval. That we studied. Well, now we talk about more about QT interval. Look into this slide again. I get one patient and look into, rather I can draw here. Look into this. QT. Now the QT interval is this much. Definitely this QT interval is more than what is there. This is the idea of telling you prolonged QT interval, which we haven't talked in great detail in class 1 drug. So we are getting prolonged QT interval in this is the example of prolonged QT. Friends, anything which can lead to prolonged QT interval, it can lead to some arrhythmias. And the name of that arrhythmia is torsades. Torsades. So as of now, note down that anything which lead to prolonged QT interval, anything which lead to prolonged QT interval can induce a new type of arrhythmia, so-called torsades. Okay, that is basic. With this background, we talk about. Let's talk about amiodarone. Amiodarone is one of the most important drug. In fact, whenever they will talk about antiarrhythmic drug, the examiner has to ask a question. He will talk about amiodarone. Invariably, 95% chances are there that if the question on antiarrhythmic drug will be amiodarone. This you should know in and out. Okay, let's talk. Well, so let's talk and learn more about amiodarone. It is a class 3 drug. That means it is going to act via potassium mediated repolarization. Agreed. We have learned that class 3 drug, they act at phase 3 where potassium efflux is occurring. Agreed. But amiodarone is the one drug, it has got class 1A property also. It has some property of class 2 and class 4 also. Oh, that means it is an all-rounder. All-rounder, it can do class 1, class 2, class 3, everything is there. Wonderful. Multi-talented. Done. So one thing, it lead to prolonged QT interval. Again, a very, very important point. The first keyword is class 3. Second keyword is class 1, 2, 4 also. And third is prolonged QT interval. There are 3 keywords to be remembered till now. Now, what I told you in the previous slide, any condition which lead to prolonged QT interval lead to torsades the point number 4. This point number 4. Well, before I discuss this, let me tell you, we are talking about prolonged QT interval. What are the conditions which can lead to prolonged? Point 5. Causes of prolonged QT interval. What are the conditions where we can see prolonged QT? It can be seen in hypokalemia, hypocalcemia, hypomagnesemia. That is so-called electrolyte imbalance. You can club into electrolyte imbalance. Then erythromycin. Erythromycin, this is the reason, the clinical applied. That's why the erythromycin should not be given in cardiac patients, especially those who have prolonged QT interval. Okay. Then drugs like 1A drugs. 1A drug is like quinidine. Then amiodarone. Okay, there are many other drugs also, the huge list is there, but as of now I'll talk what is relevant. Okay, I'm talking about amiodarone, not the prolonged QT. Okay, so there are many other drugs also, like tricyclic antidepressant are there. Well, out of these, this is the single most important cause. Single most, you forget everything, don't forget hypokalemia. It leads to prolonged QT. It's the commonest cause of prolonged QT interval in actual clinical practice. Okay. Well, all these conditions which are leading to prolonged QT interval, they themselves can induce a arrhythmia, what I torsade pointis. This I torsade pointis. Now, what type of ECG you will get it? The type of ECG you will be getting in this patient will be, okay, same, this ECG which was like this ECG will get converted into like this. This ECG will become like this. Look into this. I'll show you the picture in the coming slides. This is so-called polymorphic ECG. It twists around, this is the baseline of the ECG, it twists around, just it's twisting around the baseline. Polymorphic ECG twisting around, and this is all due to prolonged QT interval. Okay. Well, now come the gold medal line. Amiodarone is also causes prolonged QT interval. But surprisingly, this is the only condition with prolonged QT interval which does not, which is a low risk of torsade. It's not as common as compared to other drugs. We again go back. Like I mentioned to you, class 1A drug, quinidine, you remember. So quinidine is a type 1A drug which causes prolonged QT interval. So they can induce torsade pointis. That's why class 1A drugs are also known as pro-arrhythmic drugs. Why pro-arrhythmic drugs? Because they are themselves antiarrhythmic drugs. But still they can induce arrhythmia, so-called torsade pointis, because they call it to prolonged QT interval. So anti-arrhythmic drug acting like a pro-arrhythmic drug is class 1A. But amiodarone also have prolonged QT, but the chances of going into arrhythmias is less as compared to other conditions. It's not a common finding because it has got not only lead to prolonged QT interval, because there are other actions also in totality, it is a multi-talented antiarrhythmic drug. So despite having QT, there are so many reasons which prevent, because it has other action also. That's why the toxicity point does not happen despite causing prolonged QT interval. Okay. Esmolol is a beta blocker. It has got no effect on QT interval. I told you toxicity point will be occurred by any drug which is to prolong QT. Lidocaine reduces QT interval. It is a class 1B drug. So it will not lead to toxicity pointis. It's a class 1B drug. Procainamide, it increases QT interval, but its chances of going into toxicity pointis are much more. As I mentioned, any drug which is a class 1A drug which cause prolonged QT interval will lead to, in fact, all class 1A drugs are pro-arrhythmic, but amiodarone is a one drug which prolong QT with no toxicity pointis. This will lead to toxicity pointis. Verapamil is a class 4. It has got no effect on QT interval. No effect on QT. But where do verapamil act? They lead to prolonged PR interval. So they lead to AV nodal block. Remember, this also have an action on AV node. Remember, even the beta blocker have an effect on the AV node. So they are more likely to cause prolonged PR interval. But prolonged QT is done by the class 1A drug and amiodarone. But amiodarone does not lead to toxicity pointis. So golden line to remember. Amiodarone along with class 1A drug and remainder of class 3 drug, they cause prolonged QT interval. Remember, class 3 drug, the class 3 drug, what are the other class 3 drug I'm going to discuss in the coming slide, they all lead to prolonged QT interval. So in nutshell, class 1A and class 3, they cause prolonged QT. Very simple, right? Now class 3, they slow down the phase 3 repolarization. So definitely repolarization will be slow, that lead to prolonged QT. Remember, QT interval include the systole as well as diastole, depolarization as well as repolarization. Amiodarone is a unique that it does not predispose to toxicity pointis. All other drug, class A and all other class 3 drug, they will do to this problem except amiodarone, because amiodarone has got many other actions also. So friend, this is a golden line to remember in nutshell that prolonged QT is by class 1A, class 3. All these drugs except amiodarone can lead to toxicity pointis. The amiodarone does not lead to toxicity pointis. Well, we got a new drug, drug A. It causes ion flow change in cardiac muscle cell, and that action of the drug which inward ion represent the positive value and the outward is by negative value. That means this is outward flow, and this is so-called this is inward. This is inward flow, and this is outward flow. What we know, what goes in the cardiac cycle? Sodium and calcium go in. Potassium comes out. So that means we can say very light way, this should be this is coming out at potassium. This must be sodium and must be calcium. Yeah, we know it very well. Look, he's saying stage 0 sodium. Yes, this is the calcium. going in and this is potassium coming out. Simple. Well, now this for the normal and this the drug. What we notice, it has simply affected the potassium. It has got no effect on sodium, no effect on calcium, but this potassium, it changed from this, it changed from like this to this. So definitely the one drug which is blocking the potassium, and that is dophytalide. Quinidine is a class 1A drug, nothing to do with potassium. Lidocaine is class 1B, nothing to do with potassium. They are, and this is class 1C. They are all sodium channel blocker. They don't affect potassium. Verapamil is a calcium channel blocker. So I can say this is the, if I have to tell you the same thing, if I have to tell you, this is the site of, this represent class 1 drug, this represent class 3 drug, this class 4 drug, and this represent class 3 drug. Simple. All these because you know the basic. So that's why the answer of this is dophytalide, which is a potassium channel blocker. Okay. Yeah, none of the other is there. Well, question number 8, we are getting a 50-year-old male and getting treatment due to recurrent atrial fibrillation, arrhythmia resolve, mild bradycardia, prolonged QT interval. Which is the most likely drug? Lovely question. Again, which drug lead to prolonged QT interval? If I have to tell you summary, it was class 1A and class 3, right? So let's look. Metoprolol, they are class 2. They don't have effect on QT interval. Carvedilol, again, beta blocker, no effect. Is a class 4 drug, calcium channel blocker, no effect. This is a class 3 drug, and that lead to prolonged QT interval. Straightforward. Now our basic concepts are very clear, so we can see QT interval is by sotalol. Let's read more about sotalol and more about QT interval also. So as mentioned earlier, QT interval represents the period of ventricle depolarization, okay, as well as ventricle repolarization, right? So this QT interval is total ventricular cycle. Let me give you, look into this. This is systole, diastole, systole, diastole. Ventricle. Ventricle systole, this is by QRS complex. And this diastole is by ST segment. So QRS plus ST segment, they constitute entire, this constitute QT interval. So QRS, ST, QRS, ST, this whole is QT interval. The QT interval represents both acaventricular systole and diastole. Agreed. And as mentioned earlier, repolarization is mediated by the potassium efflux, that is ventricle systole, where ventricle diastole is repolarization by potassium efflux. Now sotalol, which is a class 3 drug, yes, but extra edge, it also have beta blocking action. That means it also have a class 2, and it is a very powerful class 2. Why? Let's learn. If you read any book of mnemonic, when they talk about beta blocker, that's the propranolol, metoprolol, okay, atenolol. All lols are class 2 drug. Sotalol, but it's a class 3. It's the only lol which is not class 2. It's put into class 3, but it is a very powerful class 2 also. Point to be noted, amiodarone has also class 2 action, but sotalol is much more powerful class 2 as compared to amiodarone. With this background, so we learned a special unique thing about sotalol. Now other class 3 drugs are amiodarone, we discuss, ibutilide and dofetilide. All these are class 3 drugs. So it is the only class 3 drug with beta blocking, much more powerful beta blocking. And that's why patient even develop bradycardia. You remember, read the question again. The question he said we gave, and ultimately it went into bradycardia. Look, we treated for atrial arrhythmias, and now it has gone, the heart rate may be 55, bradycardia. That can be done by a drug like sotalol. Okay. So it causes prolonged QT interval with bradycardia. So unique thing, sotalol is the one drug which can lead to bradycardia with increased QT interval. Well, option A, B, D are incorrect. They're all beta blockers only, and beta blocker doesn't have effect on the QT interval. Okay, so they are all beta blocker. They do not prolong QT interval. Diltiazem is a class 4 drug. It has got no effect on the QT interval. No effect on the QT interval. So the golden line to remember, sotalol has both beta blocking action as well as class 3 antiarrhythmic drug. So-called potassium channel blocker is this. Okay. Write down beta blocker. Class 3 drug having strong beta blocking action is sotalol. You will not forget because its name has lol also. That will again going to give an additional advantage to you in remembering as a mnemonic. Question 9, we are getting a 62-year-old male and hospitalized, 2 episodes of loss of consciousness. ECG shows polymorphic QRS complex. Polymorphic QRS complex, we talked about torsidipointis. Okay. Prolonged it has confirmed now, prolonged QT interval, which is the one drug which can lead to responsible. So a direct question to you, that polymorphic is torsidipointis, ECG is torsidipointis, and supported by prolonged QT interval. So now it's a very easy question. You have to choose a drug which can lead to prolonged QT interval. Verapamil, no way. It doesn't lead to prolonged QT. Metoprolol, no. Lidocaine reduces QT. Digoxin has got no effect on QT. Sotalol is the answer. And this you can answer because your basics are clear. Sotalol is class 3 which lead to prolonged QT interval, but one thing is there. Again, I mentioned there are so many drugs in class 3 also, including amiodarone, including sotalol, dofetilide. Out of all these class 3 drugs, every drug can go to torsidipointis except amiodarone. Point to be noted. Sotalol is the class 3, but it can go to torsidipointis. Okay. Now this is the picture what I wanted to show you. You are getting a polymorphic type of ECG recording. It twists around the baseline. Look, just twisting around the baseline is the classical finding of Why we call it polymorphic? Look into this shape of this, shape of this, shape of this. There are all different type shapes are there. That's why we call it polymorphic. Suppose you get like this. Suppose you get like this. Then all these beats are of same shape. Then we call as monomorphic. Here we are getting different shape. We call polymorphic, and this is seen with prolonged QT interval. Okay. Right. So it's always associated with prolonged QT. Torsidy point is I'm talking about. Torsidy point is it's already written by you. It always written. Prolonged QT, when they talk, they are talking about torsidy point is. And this is due to anything which is to prolonged QT interval. They already told to you. And the drugs which lead to prolonged QT, quinidine, procainamide, they are class 1A drug, is already within your notes. Disopramide, all these are the class 3 drugs. Point to noted very carefully, here the name of amiodarone is missing, because amiodarone lead to prolonged QT, but it does not lead to torsidy pointis. So now other name, all these drugs we will be calling as pro-arrhythmic drug. Why pro-arrhythmic drug? Because they are anti-arrhythmic drug, but they themselves can produce arrhythmia. That's why pro-arrhythmic drug amiodarone is not a pro-arrhythmic, or the chance of pro-arrhythmia are very less is the better word, but in medical science there is nothing like absolute. Chances are less, incidence is there. Okay. Verapamil, it lead to prolonged PR, it doesn't lead to any effect on QT interval. None of them is causing prolonged QT interval. The golden line to remember, torsidy pointis is a form of ventricular tachycardia. Is a form of ventricular tachycardia with the prolonged QT interval. So this ECG, so any ECG which has got prolonged QT interval, due to whatever reason it may be, it can go into ventricular tachycardia and so-called torsidy pointis. And this is precipitated by like antiarrhythmic drugs. I don't think I need to tell you. Tricyclic antidepressant can also lead to prolonged QT interval. Others, hypocalcemia, hypomagnesemia, and hypokalemia. So all these can lead to torsidy pointis, which is a type of ventricular tachycardia. It can go into ventricular fibrillation any moment. So that's why we have to be very, very vigilant. So in fact, in actual practice, when the patient or torsidy pointis come, first thing you do is always check the potassium. Because in actual clinical practice, low potassium level is the commonest cause of torsidy pointis. You check, and if it is low, start infusion of potassium. And at the same time, you give magnesium sulfate. Because potassium you give very slowly, you cannot give very fast. So you want to prevent that it should not go into ventricular fibrillation. The immediate treatment of torsidy pointis is magnesium sulfate injection. Okay. Well, extra knowledge, magnesium sulfate we also use in the treatment of severe asthma. Some cases. We also use in pre-eclampsia also. Okay. So there are other uses of magnesium sulfate. Question 10. Okay, physiology is working on the center, investigating effect of antiarrhythmic drug, tracing below electrical activity of a specific type of cardiac cell in experimental animal. Now, you have to tell me what type of graph is showing. Definitely it is showing graph of SA node. Am I right? Think that so. It was a cardiac, it would have been like this. Now, verapamil will have effect on which cell, which phase. What he is asking, at what phase of the verapamil, which is a class 4 antiarrhythmic drug, which is a calcium channel blocker. CCB stands for calcium channel blocker. It will be affecting at what? Slow diastolic depolarization is the answer. Slow diastolic, okay, depolarization. Well, yeah, this is the cardiac SA node. We have a phase 4 SA node, action potential. AP stand for action potential cardiac SA node. And this for stage 4 is due to sodium entry via funny sodium channel. Then we have a stage 0, phase 0, which is a slow depolarization. Slow depolarization because of calcium going inside the cell. Then we have a stage 3 where the potassium efflux occur. So when we are using this verapamil as an antiarrhythmic drug, so definitely it will be acting at this particular site, phase 0, which is a slow depolarization. Spontaneous depolarization automaticity. Point to be noted, in normal cardiac cell, it is rapid depolarization by sodium entry. But here the graph is like this, it's a slow depolarization. And that is by the calcium entry, and now no need to discuss that since the verapamil is a calcium channel blocking drug, they will be acting at slow depolarization, right? Right, sir. So, so we learn about, so we in the, as I told you, this tracing demonstrate cardiac action potential, agreed? And they are found in the cardiac slow responsive tissue such as SA node and AV node. Point to be noted, SA node and AV node which have a inherent quality. Of course, SA node is the most powerful inherent quality, but their depolarization is slow as compared to normal cardiac tissue. Okay, so the diastolic depolarization start in the phase 4. This phase 4 depolarization start, which is due to sodium entry. But after that, we have a calcium entry occurs. Both funny sodium channel, which are causing sodium to enter, start the depolarization after a certain threshold. Calcium takes over, sodium close, and calcium entry occurs. Okay. So once the membrane potential reaches the threshold, opening of calcium channel is triggered, and that result in increased calcium influx, and that start the phase 0. So phase depolarization start with the stage 4, and this is due to entry of sodium, and finally this is stage 0, which is due to calcium entry. Verapamil is a calcium channel blocker and class 4 antiarrhythmic drug. This I have spoken previously also. So we use in the treatment of supraventricular tachycardia. Why? Because they primarily, what is supraventricular tachycardia? Focus is from the atria. And they are acting, the problem is in the SA node. And these drugs are directly acting at the depolarization, calcium. And that's why they are used in supraventricular tachycardia. That's the reason. They slow down the firing, SA node firing, and they also slow down the AV conduction. So that's why they slow down, because that's why they lead to prolonged PR interval also. This is the reason. The basic concept, you know, anything which is going to block the AV node is going to cause increased PR interval. So now you understood why they are very good drug to be used in supraventricular tachycardia. They have a action on SA node. SA node firing will be reduced. They also slow down the conduction in AV node. Even the ventricle rate will go down. The two advantage of using verapamil. Side effect, it's a one drug which leads to severe constipation. It can lead to gingival hyperplasia, but this is a very commonly asked question. Constipation is a big problem when we use verapamil. Well, other action, they lower the threshold. Threshold potential is the amount of depolarization required to initiate action potential, that we know very well. Class 1A and class 4, they raise the threshold potential. They raise the threshold potential. Okay, so they are not going to lower the threshold potential. Class 1B, they shorten the duration of action potential. Okay. Then reduce the refractive period. Verapamil increases the refractive period. That's why I told you they lead to blockage at the AV node also. Class 1A and 3, they prolong duration of and increase the refractive period. We all know that class 1A drug and class 1-3 and class 3, they are causing prolonged QT interval. And they are okay, they thereby they increase the refractive period. Okay, verapamil increase the refractive period of AV node. Verapamil can decrease the amount of intracellular calcium available for excitation. Yes, it is a calcium channel blocking drug. So amount of calcium in the cell will be reduced. So it reduces myocardial contractility. That's why this drug is not used patient having congestive heart failure, because it is reducing the verapamil is reducing the intracellular calcium. In contrast, digoxin, it causes increased calcium inside the cell. That's why it causes increased cardiac contractility. That's why digoxin is used in the treatment of congestive heart failure. Verapamil is contraindicated in congestive heart failure. So golden line to remember. Verapamil is a calcium channel blocking drug. It slows depolarization of the slow responsive tissue. Slow responsive tissue are AV node. In AV node and SA node, they are going to affect the phase 0, which is due to slow inward movement of the calcium. Verapamil also decreases the amount of intracellular calcium available in cardiomyocyte. So that's why they reduce myocardial contractility also. And this is in sharp contrast to digoxin, which causes increased calcium entry into the cell, and that's why the digoxin is used in congestive heart failure. Well, friends, I hope you tried, you learned a lot. And in the very beginning only I told you it's one of the most confusing topic. Most of the people are not comfortable. In today's class also I tried to give a lot of information. You have to read it again and again to really understand. But I have some information for you. We have certain free videos, all the basic, starting any topic, starting from whole medicine. I got basic, recorded. A to Z lecture are there, extraordinary lectures are there. If you want to see, I can share you, give you some of the free videos. Okay. This link is given, which will sharing with you. One more thing, if you want that today a lot of extra material was there. If you want that that today PPT, you want to get today PPT, whatever I have given, you want we can mail you. Note down one number. Note down one number. This is the number, WhatsApp number. This is a WhatsApp number. If you are calling from outside India, don't forget to add +91. You send that, just write, I want today's PPT. Okay, that you go, just send this message. You will get a Google form, just fill up some data, and this message, the detail will be already then automatically will come to you. Even you have already filled the Google form, but you are to get this information, you have to just 2 or 3 lines you have to write in the Google form. So note down, if you want today's PPT in your system, send a WhatsApp to this. Well, friends, knowing the basic of the subject is the most essential. Whichever exam, of course, at MD level, basic concepts are required. Even PG entrance also, basic concepts are required. That is true. Now, every exam is going to be in the clinical based questions which are relevant at every step. So, if you want to go to top of the level, whichever exam you are writing, your basic concept should be very, very strong. Well, basics are like specs. You can read, suppose you use specs the way I use. You read newspaper, read book, TV, movie, football match, whatever you do. You need specs. Once specs are there, you can read newspaper, you can see TV, etc. If specs are not there, you cannot do all this. Same thing, if your basic concepts are not clear, then you cannot go to the top of the world. The golden rule of today exam, especially of those who are appearing for MD medicine or family medicine, your basic should be very, very strong, especially for in PG entrance also, those who want to get top rank, basic concept should be very, very strong. Well, when I take a class, the lectures what I am mentioning to you, I will update. Like HIV, I thought I included all these subspecialty integrated approach of 16 subjects. Anybody want to see these videos? I have for you. Well, the next D&D will be on next Sunday only, on 7th, same, 10 to 2. I'll be using more drug use in hypertension, CHF and coronary artery disease, right? So don't miss it, don't miss it. And do tell your friends also about this test and D. I have also written a book, Medicine Simplified. It's a summary of Harrison, mini Harrison, and it is available in Amazon also. Idea is to make you moon among the stars. This my idea of teaching is. I want to train in such a way that you are like a eagle which can fly at -45 to +45. It is because why? Its body is such a beautifully designed, it can adjustable to every temperature. And that is only possible when your inside is strong. Inside in the medical sciences, basic concepts are strong. I want to make you a person of this status. Rolls-Royce is the dream car for everybody. That is only possible when you know the basic concept, right? Do give feedback. Thank you very much. God bless all of you.